Thank you very much, Gwen, for that very kind introduction. And thanks to all of you for standing on the front lines, not the sidelines, of this movement to advance health equity. Today, I want to talk about why your neighbor died too young, why some zip codes feel like a life sentence, and why the most powerful prescription in America isn't written by a doctor, it's written by a politician. Most importantly, I want to share a roadmap for realizing a brighter tomorrow for the communities we serve, the communities we live in, we work in, we pray, we play in. When I wrote The Political Determinants of Health, I knew that if we could just help people see the connection between political power and human health clearly, we could change things, not tweak things at the margins, not shuffle the deck chairs, not raise our voices as an accessory to the actual conversation, actually and meaningfully change things. And then the world had the audacity to prove me right in the most painful ways imaginable. We watched the pandemic tear through this country and land hardest on the communities that political decisions made many decades earlier had already left the most vulnerable. We watched the same debates about who deserves care, who counts in the census, whose neighborhood gets resources, and whose community gets a highway play out in real time with real consequences. And I thought, this is the moment. Not because human suffering and loss is an opportunity, but because clarity is. And right now, we have clarity. If we are ever to move beyond the edges, or beyond nibbling around the edges of the problem of poor health in many of our communities, and actually achieve substantially better health outcomes, and do so with sustained investments, we all have to move upstream to the political determinants of health. We've all seen the headlines highlighting the everyday impact of the political determinants of health, the effects of which can be observed in many areas of health and healthcare, including young children growing up without mothers due to high maternal mortality, lower socioeconomic status families being funneled into substandard housing by unequal systems, and people with depression, anxiety, PTSD, bipolar disorder, drug or alcohol use disorder, or ADHD, reporting twice the odds of accessing transportation. We've all seen over the last several years the struggle to advance health equity in America and the levers of policies and politics that have been used at all levels and by all branches of government, which have affected the health outcomes of all population groups in one way or another. Research has even shown us that high obesity rates, maternal mortality, infant mortality, gun violence, depression, opioid addiction, substance use disorders, diabetes, heart disease, cancer, HIV/AIDS, and many other health problems can be firmly linked back to policy action or inaction. Research has shown the link to living in an unequal society to structural changes in the brains of children, regardless of individual wealth. Across nearly 72,000 US neighborhoods, communities facing the highest level of structural inequalities had the highest rates of heart disease, stroke, diabetes, and obesity. If we venture beyond the pond to England, we've even seen in countries around the world where policies have an effect. When in England, they introduced the Public Health Responsibility Deal in 2011, granting the food industry greater autonomy over salt reduction efforts, what happened? The prior downward trend in salt intake slowed markedly, and they saw an increase in cardiovascular disease and gastric cancer cases, which are projected to balloon significantly as of last year. The list goes on. How do we explain the fact that today in the United States, we rank 183rd for healthcare access among 195 countries in the world? How do we explain the fact that life expectancy varies by 34 years across countries. In fact, the United States has lost nearly 2 decades of progress in life expectancy compared to similarly situated countries in the world. The United States has lagged behind comparable nations in improving life expectancy, experiencing smaller gains over time, steeper declines during crises, and a notably slower pace of recovery compared to peer countries. Prior to COVID-19 striking us in the United States, there was a global health study that was published in 2019 showing that at the time when we ranked 43rd in life expectancy among all countries in the world, we were expected to drop 21 places to 64th in the world by 2040, when we were expected to become a racially pluralistic society. Because of COVID, we saw that decline happen very rapidly. By 2021, we had fallen to 60th in the world. Today, we have climbed back up to 49th, but the decrease in life expectancy continues to rapidly decrease. Let's talk about healthy life expectancy for a minute. I was talking about life expectancy, how many years of life we can expect when we're born to live on this earth. But let's talk about how many years of healthy life we can expect. Currently, in 2022, we ranked 80th in the world. And by 2050, so in 24 years, we're expected to drop to 108th. When you disaggregate the data by sex, US women are expected to fare far worse than that of men. Female life expectancy in the US is forecast to drop to 74th in 24 years, down from 19th in the world in 1990. And for all of the men who say, that's not me, I don't have to worry about it, of course you do. Male life expectancy is also expected to decrease to 65th in the world by 2050, from 35th in the world in 1990. All told, we can see the tremendous impact that this is having, not only in terms of lives lost, but in terms of economics. In one study that my team and I conducted, where we looked at the cost of the most pressing chronic diseases, the most costly chronic diseases in America, both physical and mental, what we found was that as of 2024, these racial and ethnic disparities that we observe among chronic diseases cost us $477.5 billion. By 2030, so in 4 years, we expect that number to more than double to $1 trillion. And by 2040, that magic year when we're expected to be a majority minority country, that number is expected to hit $1.3 trillion in both direct and indirect costs. So how did we calculate it? Well, we looked at several pressing chronic conditions, including diabetes, stroke, hypertension, ischemia, HIV. We looked at frequent utilization of the emergency department. We looked at productivity loss, including presenteeism, absenteeism, and unemployment. And we looked at premature death, both suicide and beyond. Today, in many communities, we see a graveyard of lost opportunities because of the struggle many people went through to attain health-sustaining and health-protective resources. Why is this happening across communities in our country? Well, today we recognize that there are a variety of forces that are collectively impacting our health and determining the quality and the extent of our lives on this earth. And they include the social determinants of health, the environmental determinants of health, economic, behavioral health, healthcare, and genetic factors. We know that numerous studies show that 80% of our health outcomes really are determined by these forces. And key among them, of course, are the social determinants of health, the structural conditions in which all of us are born into, live in, and die in, that affect all aspects of our health and well-being. And of course, these social determinants of health play an outsized role in these human-made pre-existing inequities. But underlying every single one of these is a political determinant that we can no longer ignore. You see, too often we've been stopping at the social drivers of inequities, failing to look back and dig a little bit deeper to see the depths of the problem and understand its root causes and distribution. And as a result, we've been missing the link between the social determinants of health and their policy roots. For every social determinant of health, environmental determinant of health, you name it, there was a preceding legislative, regulatory, legal, or other policy decision that resulted in the structural conditions in which we find ourselves in. Health is not a static outcome. It is a cumulative experience. At birth, policies determine whether a child's mother had access to prenatal care. In early childhood, they dictate the quality of education and nutrition that child receives. In adolescence, they decide whether that young person is exposed to environmental toxins or structural violence. In adulthood and older age, they shape access to living wages, affordable housing, preventative care, and long-term services and supports, among many others. All told, we can see the effects of political determinants of health on the health of communities. Intergenerational trauma, aggressive breast cancer prevalence among African American women, obesity, heart disease, infant and maternal mortality, and many other health issues can be firmly linked back to historical policies. We can feel the effects of inequality under our skin, which leads to accelerated aging or earlier onset of chronic diseases in our bodies, owing to these public and private policies, as well as political action or inaction. From slavery to segregation, to the contemporary poverty tax on lower socioeconomic communities, to food, pharmacy, and hospital deserts, and even climate change, they all have a compounding effect on the health and well-being of many individuals. So let's talk about the cumulative effects of health challenges. The health challenges that we all see today are the result of decades of cumulative effects on smoking rates, healthcare access, environmental exposures, and public health investments. Without conscious policy changes, these gaps will continue to persist or even widen. The benefits of health interventions, we know, also ripple across lifetimes. California is a great example. They were an early adopter of progressive public health policies like smoke-free air laws, which attributed to its substantial health gains. States with fewer tobacco regulations are still facing higher mortality rates from smoking-related illnesses. So a failure to act early and invest in public health harms future generations as well. We know that policy has been a driving force for many of the health challenges that we have seen or experienced ourselves. But it can also be a driving force for achieving optimal health in communities that you work in or seek to work in, because only policy can fix what policy broke in the first place. From the 19th Amendment to the US Constitution, which afforded women the right to vote, the Civil Rights Act of 1964, which ended segregated health care, and the Voting Rights Act of 1965, which enabled African Americans to vote in jurisdictions that had limited their right to do so, we can see the impact of structural level determinants, more specifically, the political determinants of health on population groups across the country. Today, research has shown that maternal and infant mortality rates improved by up to 15% after 19th Amendment ratification. 38,600 infant deaths were prevented because of Title VI of the Civil Rights Law. And jurisdictions that were required to comply with the Voting Rights Act saw reductions of up to 17.5% in infant deaths in their communities across the South. What does it tell us? It tells us that the fight for health equity has never been easy. It has always required vision, resilience, perseverance, and strategic leadership. Throughout our history, you can see the constant struggle, a tug of war between those advancing the political determinants of health inequities and those who have been working assiduously trying to counter the negative effects of policies by leveraging the political determinants of health. William Faulkner, the notable Southern writer, once wrote that the past is never dead. It's not even past. I want to take us back for a moment to when we became a constitutional republic. Since this year, we celebrate our 250th anniversary. It was at that point that a group of health equity advocates got together, determined to make sure that every population group, especially the most marginalized in our society, would be afforded the benefits of our social and economic policies. So they got together, the mental health reformers, advocates for homeless populations, abolitionists, women's rights, and women's health advocates, and others got together, and they strategized. And they thought about how they could get the US government, our federal government, to address the welfare issues of everyone. As they were strategizing, they recognized that they needed a major policy influencer. And so they settled upon Benjamin Franklin. And they said, Benjamin, would you please lend your name to this petition calling for the federal government to provide healthcare services for people, to provide education, to provide employment, to afford them the necessities that they need, food and clothing. And Benjamin Franklin thought about it for a while, and he says, you know what? Yes, I will lend my name to the petition. They immediately got him to sign it. That petition was sent to the US Senate and the House of Representatives. And if you think that we're having a very contentious debate over health equity in America, it seems to me that it was equally, if not more contentious from the records. At the time, once it landed in the US Congress, it created quite a stir. The Senate, the House leadership said, how dare you, Benjamin, bring up this issue when you know that we're just getting settled as a federal government? Why are you bringing this up? Now is not the time to be dealing with these issues of helping the least among us. The Senate said, we're not even going to dignify this petition with a response. But the House said, we cannot allow Benjamin Franklin to get away with this, or these health equity champions to get away with this. And so in bullet by bullet format, they responded, making the case for why the federal government could not provide for the general welfare of these marginalized groups. They made a confederalism argument. Essentially, the argument goes that, well, the states are closer to these people. Therefore, they know what's in the best interest of Black enslaved people, women, children, people with disabilities, Native American communities, and so forth. Well, by the time that petition or that response reached Benjamin Franklin, 3 weeks later, he passed away before he could respond. And that was the first time in US history that the light of health equity from a policy standpoint dimmed. It would take us 75 years later, under the presidency of Abraham Lincoln, for us to be given an opportunity to address those same issues in policy. This, of course, during the Civil War. So in 1863, President Lincoln said, we need to develop and pass a bill to help newly freed men in our society, newly freed Black folks in particular, and poor whites who are going to be displaced because of the Civil War. The US Congress said, okay. And for 2 years, as the war went on, the US Congress battled over those provisions. They finally agreed to most of them, calling for education, calling for necessities for folks, calling for employment opportunities and even security for individuals living in the South. But there was one provision that was too contentious for them to even get enough of Lincoln supporters around. And that was the provision to provide healthcare services to the newly freed people and to poor whites. So President Lincoln, in the spirit of compromise, said, go ahead, strike that provision, get that law passed, and send it to my desk and I'll sign it. That's exactly what they did. And as history tells us, 4 weeks after signing that bill into law, he was assassinated. And the supporters of Lincoln at that time, not wanting to squander the opportunity the crisis presented, said, wait a second, we believe upon rereading this law, this statute, that Congress did intend for us to provide healthcare services to newly freed people and to poor whites. And so they went about immediately recruiting physicians and nurses, clinicians all over the country from the North to come into the South and into the Midwest. They started building sanitariums or hospitals and clinics around the country. Through that major health reform law, over 500,000 Black individuals and countless white individuals received access to healthcare services. But what happens? Year after year, there's an attempt to undermine that law. And finally, on the 7th anniversary of the Freedmen's Bureau Act, opponents of that law succeeded in repealing and dismantling America's first health reform law. It would take us another 150 years for us to be able to get together and to advance a comprehensive and reticulated health policy. Of course, the Affordable Care Act that took an equity lens to it. Let me quickly talk about how we can leverage the political determinants of health. We've seen how the hierarchy of human value has evolved over time and how inequalities were structured or concretized in our policies and processes for hundreds of years. But fortunately, we know that through egalitarian policies, we have seen a direct impact, strong causation and association in better health outcomes among the populations when we do this right. We've also seen the opposite. When there's an effort to undermine these egalitarian policies, we see life expectancy declines or slow in communities across the country. Why is that? Well, let's take an example through asthma. And I want us to think about the SDOH lens versus the PDOH lens. So if you think about asthma in communities across the country, we know that many lower income and minoritized communities experience dramatically higher rates of asthma than those nearby more affluent zip codes. The same disease, different zip codes, vastly different outcomes. When you're thinking about this through a social determinants of health, SDOH identifies what is happening: poor air quality in a neighborhood, residents living near major highways, substandard housing quality, insufficient sanitation practices. The PDOH lens, or political determinants of health lens, asks the upstream questions. How did that highway get built there in the first place? Who decided to route an interstate through this neighborhood? Why was less investment made in housing materials? Who was planning and enforcing sanitation practices? A simpler way to say it is this way. The social determinants of health tell us where people are in the river's path. Political determinants of health tell us who diverted the flooding water and why they did that. Both lenses are absolutely necessary when we're analyzing a health outcome. Together, they give us the full picture and the full mandate to act. Why is this important? Why is advocacy important? Well, we know that policy is not neutral. It shapes health by design. And as we think about the political determinants of health, I oftentimes look at them in terms of 3 buckets: voting, government, and policy, from the front end to the back end. Together, they create and sustain health, or diminish health for many, many population groups. The political determinants of health. So what are they? In our country, the principal roots of current and historical challenges are found in the political determinants of health, which inequitably distribute social, medical, and other determinants. And they have created the structural barriers to health opportunities for communities. All political determinants affect every single one of us, regardless of your socioeconomic status, your race or ethnicity, your gender, your sex, you name it, because they encompass the systematic process of structuring relationships, distributing resources, administering power. They operate simultaneously in ways that mutually reinforce or influence one another to shape opportunities that either advance better health outcomes or exacerbate negative health outcomes. So let's break this tripartite definition down a little bit more. Whenever I'm analyzing a health outcome, whether it's an inequity or not, I think about them in terms of how they came to be in the first place. What was the policy that created it or has been perpetuating or exacerbating it in these communities? How did the policy or political action or inaction structure relationships in the community? How have health protective and health sustaining resources been distributed in the community? And how has power been administered in the community? Or what has been the level of political participation? And how has it been affected by governmental actions from the past? Once that analysis is done, I then create an action plan focused on the political determinants of health framework. And as you can see, when you disaggregate this into 3 buckets, these are some examples of policies that have structured relationships. From redlining under the Homeowners Loan Corporation Act to anti-miscegenation laws that are state-based laws, to blood quantum requirement laws that were imposed on Native American tribes, to immigration laws and policies that prevented children with disabilities from receiving an education in schools, to accessible housing even today for people with disabilities. When you see the middle bucket, distribution of resources, countless examples through our appropriations of federal, state, and local funds, both discretionary and non-discretionary. You can see this through Medicaid expansion, special education, home and community-based services programs, and social services programs. When you think about the administration of power, we've seen this through multiple channels, whether state versus local or federal versus state. You can see preemption issues afoot. You can see how redistricting, gerrymandering, which is about to get even worse in the South, owing to the recent Supreme Court decision. You can see an increase, or will see, in restricting ballot access, voter suppression tactics, minimizing opportunities for early voting, closing or moving polling places across communities. When the current health inequity challenges are viewed through the PDOH lens, tangible and meaningful steps within the scope of human control emerge. Actions that can be taken to better, more equitably and justly protect and preserve the health and well-being of everyone. That statement, while true, is not meant to suggest that it's an easy or straightforward path forward. However, the political determinants of health framework encompasses myriad points of influence within and throughout social, economic, and political systems. So, for example, voting, advocacy, commercial interests, government, policy, etc., that independently and in tandem exert positive or negative pressures on all individuals and communities. This complexity, I believe, demands that the political determinants of health be considered in everything that is conceptualized, planned, organized, and implemented to more meaningfully reduce the health and the other inequities plaguing the nation today. I want to leave you with 5 essential questions. 5 essential political determinants of health questions as you're thinking about how to incorporate this into your work. First, let's start on the end. What policy or policies created or mitigated the risk leading to the effects, both positive and negative, that we see today? You see, many policies create immediate or clear impact on people's health and well-being. Some policies promote fairness and opportunity, while others, intentionally or not, can create barriers that lead to unequal outcomes across different outcomes. Sometimes these effects are immediate, but often they build over time through a domino effect that ends in health challenges for certain groups. I think that by engaging in this question with curiosity, it's possible to determine if there is a policy that created an effect directly or that created circumstances that allowed or enhanced negative health outcomes. Second, could the context be influenced by government? By closely examining the processes, the regulations, the rules and norms, or other governmental practices, researchers, healthcare leaders, or providers may discover that health optimization or an effort to achieve it is either facilitated by good practices or stopped short, whether knowingly or because of a lack of understanding by government. So it is so important you drill down into those processes to understand that context. Third, how could advocacy or voting play a role in improving outcomes? A history of advocacy and high voter participation, or a lack of either, may underlie social determinants being studied. It's sometimes very hard for people to unravel whether it is a social, a political, an environmental determinant. And so this can be an essential question, the answer to which may suggest concrete plans to improve overall health outcomes. Exploring this connection can help you identify practical solutions that ensure that more people in our country have the opportunity to live healthier lives. Number 4, and this one is also critical, it's at the heart of the framework, as you saw. Are the related commercial interests aligned with improving health outcomes, or do their pursuits create or expand negative health outcomes or higher risk environments? This is a broad question and could point to specific products, marketing practices, lobbying, location of industrial sites, environmental safety, pricing of key products, and may interact with government and policy questions that relate to issues like taxes, municipal budgets, inflation, employment, unemployment, and so forth. You see, in this country, in the United States, no health inequity has ever been reduced unless their elimination or reduction served other purposes. In other words, can you show that it was palatable to the commercial interest? And can you show an investment value to the government? If those things are not aligned, we have rarely been able to succeed at advancing health equity focused policies. So it's important that you understand the interplay between commercial interests and the government. Number 5, how do the above political determinants interact or intersect with each other in this particular project or program? If you are developing an intervention for the community, it's so important because the political determinants of health model is nonlinear. It's a complex web of influences. So it's valuable to step back after asking the above questions and ask how these elements have interacted to create the world we inhabit. When these questions are included throughout our practice, your research, education, our collective understanding will be enhanced. And the concrete nature of these discoveries will lead to meaningful steps toward improving the health of all communities. Lastly, I want to also offer some further insights on the political determinants of health by asking you to ask yourselves these questions. What limitations and barriers can be identified for the community on which your intervention focuses? And lastly, does the intervention identify and/or uplift populations that have been identified as historically marginalized, under-resourced, or vulnerable? So where do we go from here? As I close, I wanted to now pull it all together. I know many of us operate in the healthcare space, and I thought it's important to highlight this intersectional issue. We know that social and political determinants of health shape outcomes. And yet, through several studies and reports that were published by the National Academy of Medicine, they have echoed this sentiment that the US has made little progress in advancing healthcare equity over the past 2 decades. And racial and ethnic inequities remain a fundamental flaw of the nation's healthcare system. They also state that the healthcare system has failed to adopt at scale many of the known solutions for improving healthcare equity. And they also highlight the fact that the social determinants are not context. They are causal conditions that shape prevention, adherence, and exposure to risk. We know the gap that we have to close. Social determinants of health are often acknowledged, but they are not integrated into our health system. A scan of interventions that I was asked to review by the National Academy of Medicine showed that interventions have been developed and implemented across the United States. And they show that the social determinants of health are usually used to target the provision of healthcare services in communities, but they're not actually addressing the root causes of these social determinants of health, the structural conditions in which folks live in and age in. The literature highlights that adoption is growing, but implementation and sustainability challenges remain, especially without strong cross-sector partnerships. Are we then surprised that we have seen little success in many of the interventions that have been developed today at the clinical side in healthcare? Well, we shouldn't, because as researchers have documented, downstream interventions which focus on change at the individual level are more likely to increase health inequality than our upstream interventions, which focus on social change or policy change. Knowing that, I want to leave you with 4 things to think about as you think about how you might apply the political determinants of health in your work. Measurement and metrics. We know that what gets measured gets prioritized. And so I want to urge you to think about first policy adoption and implementation. We know that data infrastructure is a form of measurement. You cannot fix what you cannot see. And some of our society's most pervasive and insidious disparities like to hide in the data. Second, civic participation metrics by community. I think this is so important that we track decisions that invalidate voting protections for racial and ethnic minorities and other minoritized individuals, because these prevent marginalized communities from fully participating in the electoral process. When communities cannot participate politically, their health follows. The ballot box is a health metric. Third, we need to track budgets. Where a government puts its money is the truest statement of its values. Budget allocations are health metrics. Follow the money and you'll be able to follow the determinants. And lastly, we need to create a political vulnerability index. These composite measures capture the accumulated effect of political decisions over time. Let me end with this call to action. We in the United States have experienced 4 health equity awakenings. You heard me mention Abraham Lincoln's policy to address the social determinants of health needs and provide health care to newly freed Black people and poor white people. That was the first awakening. It was then followed almost by a 100-year period of retrenchment and regression. But then the second awakening opened up for us, where we were able to focus on the desegregation of hospitals in the 1960s, owing to the Medicare and Medicaid legislation, the Civil Rights Act, the Fair Housing Act, the Voting Rights Act, and other policies that were addressing the overt barriers to healthcare access. Then we had another period of retrenchment and regression. That lasted until an opportunity opened for us to address the more subtle forms of discrimination in our society and in healthcare, those pesky disparities in health status and healthcare, through the passage of public policies, including the Affordable Care Act, that were intended to address these issues. That then led to a period of regression. But then we were able to open up a fourth awakening, where we got to harness the powerful levers of multiple sectors to optimize and address the upstream determinants of health. It is not lost on me that we are living in now a very dark and challenging time. We're living in a period of regression and retrenchment. There is no doubt from a health equity standpoint. But folks say, but Daniel, why are you so hopeful then? You're feeling, you're experiencing it. You can see how we're backsliding in terms of many of these policies. That is true, but we have always had these periods where we have been backsliding. Thankfully, we have always had health equity champions like yourselves who were unwilling to allow the pendulum to swing and unravel all of the gains that had been made at that point. And I believe through your efforts, we will continue to realize progress. Every single period of retrenchment and regression that we've experienced continues to get shorter and shorter. That is what gives me hope. And so I want to leave you with this last thought from my dear friend and mentor, Dr. David Satcher, who served as our 16th Surgeon General of the United States. He was a man who dared to be bold in health policy, to address the underrated issues in policy that no one else wanted to touch, from mental and behavioral health to sexual health to oral health and beyond. He was the first in our country to say, we shouldn't just be reducing health disparities, we should be eliminating disparities. And at the height of COVID-19, Dr. Satcher said to me, Daniel, what we need now more than ever are leaders who care enough, know enough, have the courage to do enough, and will persevere until the job is done. First, we need leaders who care deeply about our communities. But as you have heard today, caring is simply by itself not enough. You have to avail yourselves of the knowledge of these political drivers of health. You've also heard about this movement to advance health equity. It is not for the faint of heart. We need folks to recognize that you need tremendous courage to continue to move the needle forward. And it is a long game. We need to persevere until the job is done and not give up hope so quickly. Thank you all again for the privilege of your time. And I want to urge you to continue standing with the marginalized until we have erased the margins. Thank you all again.
Thank you so much, Daniel Dawes. I love the last thought that you left us with, is that we stand with the marginalized until we've erased the margins, which I think is really the something that most of us who are on this webinar and who are interested and committed to health equity really feel very, very strongly about. And as I was thinking about your talk, I was listening to you, and I was madly taking notes on my notes that I had madly put here before. I think I need to listen to it 3 or 4 more times, and then we can pull out all the richness and the rigor and the challenges that are in this, the challenges that are in your in what you've described for us, and the challenges from what we live from every day. And one of the things that shocks me, and it also, you live in the South, I live in the North. I live in New York City, which is its own little bubble. I'm the proud daughter of an immigrant from Iran. And it is, I think about the differences in the places, my place here in New York and my friend Freddie White Johnson's living in the Mississippi Delta, and what our experiences are of life and what our experiences are of access. And one of the things that shocks me, and has always shocked me the most, is how little people know about our history. How many people, I remember having somebody who was a senior program officer at a foundation tell me that she hadn't heard about redlining until she had read Isabel Wilkerson's book, Warmth of Other Suns. So I think we've got many people of good faith, many people with very good intentions, who also don't know our history and they don't know our context. So I think that is a really potentially very important place to start. And one of the things that you talked about in your book was the lesson that advocates took from the past, that attempts at advancing health equity included the need to persist through crisis and operate with a sense of urgency. And as we're looking at the time that we're in, we're all looking for places where we can persist through crisis, and where are acting with a sense of urgency, where we really have an opportunity to do that. And are there, as we think about the audience that's here and the people who are going to see this after today, are there places that you think that we can look to really persist through the crisis?
So the question is yes. And I did want to make a comment. You really jogged my memory about a famous line that Reverend Dr. Martin Luther King Jr. had stated, that the forces of ill will have used time much more effectively than the forces of goodwill. It's something to think about as we think about the need for urgency in our advocacy at this moment and at all times, quite frankly. You also mentioned something that I find very interesting when you talked about the geographic disparities between the North and the South. Yale University School of Public Health had actually published a really interesting report looking at about 100 years of data from the 1900s to 2000. And they disaggregated the data based on sex, male, female, and they looked at it in terms of the states. So they looked at the data state by state. And what they found was that over the 100 years, those in the North, both men and women, had seen significant increases in their life expectancy. For women, up to 30 years in the Northeast. So for those of you in New York, yes, Massachusetts, DC, Connecticut, you all are doing very well in terms of addressing these political determinants of health and increasing healthcare access. In the South, you can see over a 100-year period that for men and women, we barely added even a year or two onto their lives, and that has remained stagnant. Why is that? Why is that? Well, a great example, since you asked me for some examples, a great example is one where both Oklahoma and Connecticut were examined in terms of life expectancy. They looked at the data at Syracuse University and from the early 1970s until today. And what they found was that both Oklahoma in the South and Connecticut in the Northeast had the same exact life expectancy. But what happens? As the decades go, we see a divergence, significant divergence, slowing down of life expectancy in Oklahoma and increases onto years of life expectancy in Connecticut. And I thought, this is fascinating. I wonder why that is. And of course, some of the assessment reveals that from a policy standpoint, Oklahoma adopted this rugged individualistic approach to policy. They were not supportive of policies that would grant folks opportunities for, family leave, for workplace benefits and so forth, whereas Connecticut went full in that respect, and other areas in the South. We also saw a slower response in adopting Medicaid in the South than we did in the Northeast. The same thing with tobacco laws. In Oklahoma, slower attempts to prohibit smoking in restaurants and in other rooms, public places and accommodations, whereas in the Northeast, they did that. So you can see over time how this translates to better health outcomes and healthy life expectancy in these communities. So I think those are some great examples of how to move the needle forward.
And I think the other thing that you certainly talked about throughout your talk was this idea that we don't we make these assumptions about things, and we don't necessarily, and the assumptions, and we rarely question our assumptions. It's like people, the last time they know about biology is when they took high school biology. The last time they know about history is when they, had seventh grade, one of those American Parade or whatever those books were called. And we don't continue to learn, and we don't continue to ask questions. And so as I mentioned, we've been doing a lot of work in the Mississippi Delta and had a long-term partnership there. And people make assumptions about why there's not much access to care, why the access to care there is so difficult. But one of the things that they always leave out is that there are no healthcare providers. So there are so many, it's so multifactorial. And when we look at the differences between that, and we look at some place like New York where I live, where it's a very medically rich society. It's very medically rich for most people, but not all people. And so we don't always dig in what happens, and the way that we look at these differences, the way that we look at differences in maternal mortality rates, people make assumptions that it's because of socioeconomic status, but really it is primarily because of race. And so I guess this isn't really, I don't know if it's not really a question, but it's more of a comment, is it feels like one of our roles in all of our health equity work is to continue to question assumptions and continue to make a commitment to learning, but also could make a commitment to learning from people and to learning with people, because otherwise we'll keep on doing the same thing over and over and over again.
Yeah, absolutely, Gwen. And even though it wasn't a question, it was a comment. I do want to comment to that because I think it's a valid point that you make. And it reminds me of an article that I had published with Dr. Vincent Guillermo Ramos at Johns Hopkins University, where we looked at the myth of the zero-sum game. So there are several myths that I've experienced from those who have been hesitant, and may not want to advance health equity because they subscribe to this myth of the zero-sum game. That if this policy benefits this group, then I, on this other group, am going to lose out on these social and economic benefits myself. Nothing could be further from the truth, as we have seen through egalitarian policies, as we've done epigenetic research, as we have done health services research. Nancy Krieger at Harvard has done a phenomenal job, and others, of course, highlighting these connections between egalitarian policies, and better health outcomes versus the opposite. So I do think that needs to be addressed. And then the myth of complexity, I've heard over and over again that, oh my goodness, this is such a complicated issue. I mean, you talked about multifactorial, issues, and yes, it is very complex, but still, it's fascinating to me how many folks will not take the time then to learn how these levers have been pushed and pulled over time in order to effect the kind of changes that they need in their community. And so I do think, to an extent, that myth of complexity and the myth of zero-sum game needs to be addressed head on by proponents of health equity.
Yes. And I think that the myth of the zero-sum game and the call to solidarity is extremely important. And
Yes.
one of the books that has inspired me and energized me the most that I've read in years is Heather McGhee's The Sum of Us.
Yes.
Because it really calls us to be together and to be in solidarity. And I think that's also something that you do, and you put a different lens on this, because if we don't solve these political problems, we're never going to have health equity. And I think that people forget that. I think they forget that, and they forget, we think about budgets as important, but we don't necessarily look at that from a political perspective. We look at that from what is the hospital spending, or what is the healthcare system doing, but we don't look at it that way. And the other issue that is so heartbreaking, and is throughout everything that you've talked about, is this idea of deserving and undeserving. And from the beginning of your story about the highlights in health equity, that has really been one of the most, that to me is a theme that we who are committed to health equity really need to address and something that we need to I don't know how we help people understand it, but everybody is deserving of health. Everybody's deserving of health and happiness, and the that 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 theme that goes throughout, who deserves health, who doesn't deserve health, who deserves this, who doesn't deserve that, is one of the most difficult, one of the most difficult and one of the most disruptive aspects of the way that we of this country, and how we have developed, how this country has developed over, as you mentioned, the 250 years.
Yeah, I think you're absolutely right. I mean, to the first part of your statement, I do agree that health equity is political equity, right? And vice versa.
Yeah.
I do also think that it's important that we subscribe to the moral determinants of health. I know Don Berwick has been advancing that, and I do think that is the most aspirational thing we can do as a society, so that we see one another. We understand that we're all interconnected, interdependent. Our success depends on the success of each and every group within the society. And until we recognize that, we will continue to all suffer.
Right.
It's been shown time and time again, as I mentioned, that when one group is suffering, it pulls down the nation. You too suffer. We have seen white communities in the United States. They are not on par with white communities in Europe that have substantially higher life expectancies than what we are seeing in this country. So these policies absolutely matter. When we're fighting for healthcare access, when we are striving to stretch the umbrella of inclusion in health policy, it benefits every single one. And that goes back to what I was mentioning with the myth of the zero-sum game, that there's so many folks who, believe without evidence that when you advance an egalitarian policy, it hurts another group of people that has been benefiting from existing status quo. That is not how we have seen it in the data. The data does not present that. The evidence does not present that. So I think that's worth continuing to push back on and educating folks, especially those who are naysayers, who have made up their mind that no, this is exactly what happens. No, let's have a conversation. They're willing to have the conversations. I do think it's important that we talk to everyone who's willing to have a conversation and learn.
Mm-hmm. Thank you so much, Daniel Dawes. This has been a phenomenal keynote, and really setting the stage for incredible conversations and incredible progress. Thank you so much.
Thank you for having me, Gwen. I appreciate it.